With me, Professor Natarajan. He is the President of Tele Society of India. Dr. Manoj Chandra Mathur, everybody knows, he is the Treasurer of AIOCMTC and also the member of our team, Tele Society team. Myself, Dr. BNR Subudhi, Secretary, Tele Society of India. So we start the session with me only. So I will start the session with the introduction. Can you please focus my ear? Good morning, delegates. So it's a wonderful day at Vizag. It's really one of the wonderful conferences we have. This is our program, today's program. I thank AIOCMTC giving us a full session of 75 minutes in the All India conference, both in the main conference and the midterm conference. And our session, it's a teleophthalmology. There's a lot of people that do not know till now what is the teleophthalmology. But of late, Tele Society of India has done a lot of programs all over the country. As you know, telepathy is a branch of telemedicine that delivers eye care through digital medical equipment and telecommunication technology. Today, applications of teleophthalmology encompass access to eye specialists for patients in remote areas, ophthalmic disease screening, diagnosis and monitoring, as well as distant learning. Blindness is a major trauma which affects an individual not only physically but emotionally too. It is a global phenomena, and in spite of all our efforts of reducing the blindness, it's increasing. 82% of people, blind people, are above 50 years. They live in the rural areas, unreached areas. Basically, lots of these people who live in the rural villages, in the hilly areas, are suffering from preventable eye disease, and some are blind within them and do not get proper treatment and screening of their eyes because of non-availability of ophthalmologists and infrastructures. And as you know, India is one of the country where there are shortage of doctors, shortage of ophthalmologists. We are about only 20,000 ophthalmologists to the huge population of 140 crores. So there is a disproportionate doctor-patient relation or doctor-population relation. So, and majority of these 20,000 ophthalmologists, they are concentrating in the urban areas only. They do not want to go to the villages. So how to take these people to the villages? So again, infrastructures in the rural areas are very, very poor. Lot of our regions are ill-traveled. They no accommodation, no transport, everything. The doctors find a lot of difficulties in going there and staying for months together to treat the people. So the lack of transport, lack of financial status of the patients make it even more difficult to provide healthcare in the rural areas. So here comes the role of teleophthalmology. It is a branch of telemedicine or telehealth that has evolved into the integral clinical tool in the Indian healthcare system. Of late, during the COVID time, you must have seen how teleophthalmology came into the rescue for the patients who have been operated quite before. For the screening purpose, for the follow-up purpose, teleophthalmology is one of the branch which has came into the prominence. It allowed clinicians to provide quality healthcare outside their clinics through the digital technology, thus improving access to medical care, better patient outcomes, and overall patient satisfaction, because patients did not have to travel a long distance to show either for the post-operative follow-up to the doctors. It's a very effective model for improving eye care delivery system in the rural and underserved areas of our country. It is a rapidly developing field. It has the potential to improve ophthalmic care and diagnose many eye diseases in early stage. That is very important, diabetic retinopathy, glaucoma, even refractive errors also. If you detect them early, probably you can prevent this blindness. Ultimately, the goal of teleophthalmology is to decrease the global burden of vision-threatening disease and improve the quality of life of patients with eye diseases worldwide. It will provide high quality, cost-effective community eye care at the doorsteps of the community. Thus, it can be a very effective model for the improving eye care delivery system in India. The objectives of teleophthalmology is to make eye care service accessible and affordable by reducing travel costs and time for the patients, to enable people at remote areas to have access to the specialist eye clinic or eye care facilities which are available in the urban areas only. So, taking into account, we have seen that a lot of teleophthalmology services have been carried out by various centers like Shankar Nethralaya, Arvind Eye Hospital, then LVS, but they are all scattered during the different places. So, our aim is to integrate all these systems into one system so that everybody can do the same thing and it can reach the common ophthalmologist. So, thus, Teleophthalmology Society of India is formed in April 2021 to bring all people who are doing teleophthalmology into one system and under one banner. So Tosi was born on that day with Professor Natarajan, Padma Shri Professor Natarajan being the president, and Dr. Kim, the president-elect, and Dr. Rajiv Ramman were the leading pioneers in teleophthalmology. They are the office bearers of the society. So the dream of Teleophthalmology Society, dream of eye care should reach every village in India. So there are about 369 villages in India. So eye care should reach each one of them. And to eliminate diabetic-related blindness from India by 2025 and eventually the world, that is our vision of our president, Dr. Natarajan, we must screen all diabetes in our country. The diabetes has increased phenomenally in the last 5 years, I would say. It was 80 million sometime back, now it's crossed 100 million in our country. So outline the components with the use of smartphone to take good retinal photographs, portable, sustainable and cost-effective equipment of screening for screening a large population, training unskilled workers to make them semi-skilled, and generating employment among the uneducated youth of India, preventing them from being burdened to the society. Generating enough manpower to screen diabetics in 764 villages of India. So these are some of the eye care devices available. They are portable, also economically viable for people to carry them to the rural areas to do the screening of many ideas, like even cataract also can be screened of these devices, glaucoma, diabetic retinopathy, ARMD, refractive errors also. So teleophthalmology advantages extensive outreach, avoiding unnecessary referrals, health education, timely intervention in emergency situation, saves cost and time for the patient, and it's a professional opinion can be delivered to the people, even practitioners too. Protection against the infection which we have seen during the COVID infection. New additions to teleophthalmology are the teleophthalmology with artificial intelligence. Some of the speakers will speak about artificial intelligence. 5G is giving the fastest transmission of the data from one center to another center, and of course another 5 years we are getting 6G also, still faster. A metaverse, establishing virtual clinics in the rural areas, that will also help the poor community patients. So teleophthalmology in future, what we aim that teleophthalmology ATM is a one-stop digital touch point integrated machine designated to direct the digits and deliver primary care. These are planning in the future. They already come up. Some China-based companies already come with the ATMs which can be installed in various public places like stations, airports, where a person can enter into this and just check his eye whether it is referable or not referable. That's very important, particularly diabetes and glaucoma cases.
Teleophthalmology is a form of virtual eye care consultation that can be conducted remotely. MedicMind provides patients with equitable and affordable eye care. Designed in New Zealand for the world, we bring you the Teleophthalmology portal. It is a cost-effective method to reach out to your clients. This is extremely useful for consultation from remote locations, which could save clients from travelling to a tertiary hospital. MedicMind service is simple, secure and free. It is easy to set up without any downloads. The portal's video conferencing tool is encrypted with the highest level of security, technical and industry compliance. Confidently schedule and launch meetings from your web browser, whether it is from your mobile phone, iPad, laptop or desktop computer. It is as simple as clicking a link. With Teleslit lamp and Teleretina provided by Odox Eye Care, live retinal examination can be performed with a virtual meeting via video or mobile adapters. Consulting specialists can now view the patient's eye remotely. Empower your clinical care now. Saving sight made easy.
So thus, Teleophthalmology Society of India is formed. The form is available with us. Please do contact, be a member of society and share your experience with us, which can be transferred to some of the members all over the country. And recently we had a discussion with our SAARC countries, SAARC counterparts like Sri Lanka, Bangladesh, Nepal, to start their society and to coordinate with each other, forming a SAARC Teleophthalmology Society. Status is under cards. We are in the process of developing this society. So I request our president to take also interest in the formation of this SAARC Teleophthalmology Society. I have already discussed with them. So let us all invite SAARC countries representatives once and propose the formation of society for the integrating teleophthalmology service of all the SAARC countries. The aim is to coordinate teleophthalmology services of all SAARC countries for the benefit of the common man in the subcontinent. So this is the session today. We have got speakers. Will be anything you do, you have to follow some guidelines. So I have with me Dr. Manoj Chandra Mathur. Everybody is well-known figure in India. He is the treasurer of our country, AIOS. He is our dynamic treasurer of AIOS. He is a brilliant academic career and extracurricular record in college, and after PG, he underwent a long-term fellowship in glaucoma. He is a private practitioner based in Hyderabad, and he's got several scientific presentations, state and national levels. I will take another 2 minutes. So he will be speaking on the guidelines of teleophthalmology. Of course, our Teleophthalmology Society is surrounding this person, great person, who is a Padma Shri awardee, Professor Natarajan, our dynamic past president of AIOS, and now also is very much active in the society, not only in India, all over the country. He is the brand ambassador of teleophthalmology in abroad. So everybody knows him very well. He is honored by the government of India with the Padma Shri. He has dedicated his life toward the rendering human service to the mankind by treating the vision impaired. After achieving the clinical success in ophthalmology, now he is dedicating his whole life for the community, basically mostly for the diabetes and diabetic retinopathy. So not just a surgeon, is looked up as healer by those shattered by the vision loss. Mostly you must have seen in the Kashmir with the bullet injuries, how much he has served our country and the people there. He is the founder, chairman and managing director of the well-reputed Aditya Jyot Eye Hospital at Mumbai. Dr. Sudhanshu Mathur is again a consultant and Chamunda Hospital and the High-Tech Eye Hospital in Kasipur, Uttaranchal. He is also chairman scientific and AIOCMTC2, treasurer of BS, all those societies mostly associated. He will be speaking, he will be one of our speakers in this program. Dr. Arvind Moria, he is the additional professor and head of the Department of Ophthalmology, All India Institute of Medical Sciences, Hyderabad. He has been awarded Srimati R.K. Devi Memorial AIOCMTC International Level for the Excellence. He is very much associated with the community of ophthalmology. And of course, last but not the young, dynamic Prasanna Venkatesh is the research director and glaucoma head at Mahatma Eye Hospital at Trichy. He has got delivered a lot of scientific topics in the teleophthalmology and also metaverse in ophthalmology. He is the chief instructor and faculty in various national and international conferences. He will be our last speaker in this today's program. So thank you very much for joining with us for the teleophthalmology session. Now I request our treasurer AIOS and the member of AIOS, Tausi, to speak on the guidelines about the teleophthalmology. So whatever you do, you have to follow certain rules. You must have to limit it because otherwise you will be in the trouble. So I request Dr. Mathur to come back and speak about the guidelines of teleophthalmology. Thank you. Thank you, everybody.
And Dr. Subudhi, thank you very much for a wonderful talk. But we only have 3 audience, I think. 1, 2, and 3, and 2 are I brought them. Dr. Shonraj and Anusha, and only 1 more is there. So, anyway, thank you for coming. He's a PhD from Melbourne with Remedio. So you have to give some comments. No, make it, they're recording. It will be there on the record.
So good morning. Thank you, Dr. Subudhi and Dr. Natarajan, for giving me this opportunity. I shall be speaking about the government guidelines in telemedicine. So as Dr. Subudhi has already introduced the topic, that it leads to timely access to appropriate optimal interventions, faster access to services that may not be otherwise available, and the financial costs associated with travel would be reduced with telemedicine. So they can particularly play an important role, especially for regular routine checkups or continuous monitoring, if not the original consultation. and it can certainly reduce the burden on secondary hospitals. With telemedicine, maintenance of records and documentation is inherent, and written documentation increases the legal protection for both the patient and the practitioner. So all these guidelines, all these regulations were existing, and these acts primarily govern the practice of medicine and information technology, but gray areas and gaps in legislation and the uncertainty of rules posed a risk for both the doctors and the patients. So COVID-19 precipitated a crisis, and the positive outcome of that is basically telemedicine. It had an adverse impact on the quality and the standard of healthcare, and to address this need in the wake of COVID-19 outbreak, the government legalized the mainstreaming telemedicine in health systems to minimize inequity and barriers to access. So by a public notice, MCI 211 of 2019, they incorporated an amendment in the Indian Medical Council Act titled as Consultation by Telemedicine in the said regulations. The telemedicine practice guidelines were issued as Appendix 5. So they defined telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communications technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and the continuing education of healthcare workers with the aim of advancing the health of individuals and communities. The definition of registered medical practitioner was defined by this act as a is defined as a person who is enrolled in the state medical register or the Indian medical register under the IMC Act. There is a difference between the definition of telehealth and telemedicine. Telehealth is defined as the delivery and facilitation of health and health-related services, including medical care, provider and patient education, health information services, and self-care via telecommunications and digital communication technologies. In general, telemedicine is used to denote clinical service delivered by a RMP, while telehealth is a broader term of use for of technology for health and health-related services, including telemedicine. So, the registered medical practitioners are entitled to private telemedicine. All of them will take an online course in practice of telemedicine. This was the original plan of the government, but now since we have reverted back to the physical mode of practice, this telemedicine course is yet to be introduced and yet to become binding on the RMPs. To enable all those RMPs who would want to practice telemedicine get familiar with these guidelines as well as the process of limitations of telemedicine practice, this online course was to be developed. Now I am using the replacing the word will to be developed, was to be developed, and it is yet not done. So the guidelines of telemedicine basically involve the professional judgment of an RMP should be guiding principle for all telemedicine consultations. An RMP is well positioned to decide whether their technology-based consultation is sufficient or an in-person review is needed. No compromise on quality of care. Tomorrow if something happens, you are equally held negligent for physical consultation as also telemedicine. So we need to take all kind of precautions. So basically telemedicine involves 7 elements need to be considered before beginning any telemedicine consultation. What are these 7 elements? The context of consultation, identification of RMP and patient, mode of communication, consent, type of consultation, patient evaluation, and then patient management. So what is the context? The RMP should exercise their professional judgment to decide whether a telemedicine consultation is appropriate in a given situation or an in-person consultation. They should take a clear call. They should consider the mode technologies available and their adequacy for a diagnosis. The RMP shall uphold the same standard of care as in-person consultation, but within the intrinsic limits of telemedicine. The identification of a patient, if the patient is present in person, this thing, but for telemedicine, the RMP should verify and confirm the patient's identity. by name, age, address, email ID or phone number or registered ID as appropriate. Where the patient is a minor, after confirming the age, teleconsultation is allowed only if the minor is consulting in the presence of an identified adult. And every RMP shall display the registration number on the prescription website as we do for physical consultation. The mode of communication. Multiple technologies can be used to deliver telemedicine consultations. Primarily, there are three modes: video, audio, or text, that is chat, images, messaging. There may be situations where in order to reach a diagnosis and to understand the context better, a real-time consultation may be preferable over an asynchronous exchange of information. The consent. The patient consent is necessary for any telemedicine consultation. The consent can be implied or explicit. What does it mean? If the patient initiates the telemedicine consultation, then the consent is implied. Explicit patient consent is needed if a health worker or an RMP or a caregiver initiates the telemedicine consultation, and then that is referred to the RMP. The patient information, the RMPs must gather sufficient information before making any professional judgment. An RMP would use his or her professional discretion to gather the type of extent of information. This information can be supplemented through conversation with the healthcare worker, provider, or by any information supported by technology-based tools. If an RMP feels that the information received is inadequate, then he can request for additional information in real time or shared later via email or text as per the nature of such information. For example, an RMP may advise some laboratory and or radiological tests to the patients, and that reports can be shared by in asynchronous methods. The telemedicine has its own set of limitations. The RMP should not proceed until a physical examination can be arranged through an in-person consult. Examination by another RMP or health worker, or in-person consultation. The information required may vary from one RMP to another based on his or her professional experience and discretion, and for different medical conditions based on the defined clinical standards and standard treatment guidelines. Then the first consultation and follow-up consultations, what are the guidelines? The first consult should preferably be via video for better judgment and better advice. If the patient is seen in person earlier by the RMP, then it is possible to be more comprehensive in managing the patient. The first consult means the patient is consulting with the RMP for the first time, or if the patient has consulted with the RMP earlier, but over 6 months' time has elapsed, and the patient has consulted with the RMP earlier, but for a different health condition. In these three situations, it is considered as a first consult. Then the follow-up consults are further defined due to the paucity of time. I would like to proceed further. The patient management is important. The counseling can be done on how the prescription of the medicine should be taken up. While prescribing medicines without an appropriate diagnosis and provisional diagnosis will amount to professional misconduct. So before you prescribe any medicine, the diagnosis is most important, and prescribing limitations have specific restrictions on limitations on prescribing medicines. The medicines are classified as O, A, and B list. What is O list? Is something like an over-the-counter medications which can be used for common things like, for instance, paracetamol, ORS solutions, cough lozenges, etc. What is list A? These are the medicines which can be prescribed through the first consult, or which is a video consultation, and subsequently they can be added to the initial consultation. What is list B? List B is a list of medication where RMP can prescribe in a patient who is undergoing follow-up consultation, in addition to those which have been prescribed during the in-person consult for the same medical consultation. And a prohibited list, if RMP providing consultation where telemedicine cannot provide the prohibited list. So these are the lists O, A, and B prohibited, and these are the matrix which decides what kind of medication can be prescribed through telemedicine. Issue a prescription with all your letterhead, with the registration number, with all the required criteria. RMP should provide a photo scan, digital copy of this signed prescription, and the patient, this data has to be maintained by the RMP for future use. Thank you very much for your patient hearing.
Now, thank you, Dr. Monas. I think giving us a brief outline of guidelines. So whatever you do is to follow the guidelines, then only will be in the safe side, because there are medical legal issues may come up. So now I request invite our President, Dr. Natarajan, to speak, and because teleophthalmology is expanding. Now with artificial intelligence, we can do a lot of things, particularly in the rural areas where the manpower is a shortage and we will not have much manpower. So where we can utilize our artificial intelligence with paramedics and optometrists, where we can have all the pictures we want to screen the patients. So it's over to Dr. Natarajan. Please.
Thank you, Dr. Subudhi and Dr. Manoj Mathur. So Dr. Arun Murray has just come, and Dr. Shonraj is here. I think this presentation is only for you, because I want you to give input. Subudhi, Dr. Subudhi, Dr. Shonraj is a PhD, is a Elite School of Optometry alumni and PhD in AI so he's also now just joined as a faculty with the Chief of the Clinical Services of Remedio. So we are now doing a Maharashtra Ophthalmic Society. I am the chairman of Diabetic Retinopathy Committee. So we had a meeting day yesterday. So we are going to screen all the 37 districts using the AI with the Remedio. And they have promised they will cover 100 centers. Apart from that, whoever has camera, we are going to do. So same thing, you can also plan for under TOSI in Orissa, all districts. And so can machines think? This is what the question asked in 1950, and I think now you know there are fiction movies, and robot is a great example. And computing machine like intelligence was first talked about in 1950, established the fundamental goal and vision of AI. And AI is a branch of computer science that aims to answer Turing's question in the affirmative. It is the endeavor to replicate or simulate human intelligence in machining. But many times I think the human intelligence gets bored and you don't analyze properly. It's like the clinical practice. You have the clinical acumen, but if you don't apply to that single patient, it's a problem. But the computer will do it automatically, a machine that thinks like a human. And the types of AI, you have the narrow artificial intelligence, which is a weak AI, like the Siri, the Google has, the Amazon Alexa, and then the artificial general intelligence, the strong AI, like you have these various things, and AI enabling machines to think like humans, machine learning, training machines to get better at a task without explicit programming, deep learning using multi-layered networks for machine learning. In ophthalmology, AI is seen to have unlimited potential to perform many tasks as well as or even much better than humans. It is seen to be very good as. I think there is the ego with the human, so I think the slide has to be changed. The reason is, I think AI has its own merits and human has its own merit, but I always tell, as an advanced vitreoretinal surgeon and an aggressive vitreoretinal surgeon managing a lot of complicated machines, and I think you have to be the master of the machine. Same thing here, AI is created by human, and I think you can see in the science fiction, AI will take over and they say that it can have a problem. But I think we have to have a balance, and I remember when first I started giving talk, they will ask a question, will AI replace doctor? No, it's never going to replace. AI will be a good assistant, but you have to make, it is like the master is always important. So it has to be, it's like that even the you have to learn to use this. It is seen to be very good as diagnostic tool, grade the severity of it. All this is a mechanical job by a doctor. So I think we can replace this with the AI, and early disease detection, screening tool, and prediction of the evolution of a disease. Now we are the first ones in the world to use a I won't say illiterate, school dropouts, like the health workers and the peons in my organization. From 2014, we are making them use the retina fundus photograph. They make better photograph than a postgraduate or a retina fellow. So that we can save the doctor's time, not even the paramedical, and I think we can use anybody. And we have a, what do you call, the Romeo police in UP. I always tell, why should they have a Romeo police to control this? I think they can be given a job to do like this, so they can take part in healthcare, and that's my dream. As Dr. Subudhi said, I have actually dedicated my rest of my life to make sure we reach 6,47,745 villages in India. So this is AI and deep learning in ophthalmology, first published by the Teen Wong group, and then in the Asia Pacific journal, can AI make screening faster, more accurate and more accessible, and then AI and OCT imaging from the US. And then AI and deep learning in ophthalmology, deep learning for detection of diabetic eye disease by Lily Peng from the Google group, and AI and optical commerce and development and validation of a deep learning system for diabetic retinopathy and related eye disease using retinal images from multi-ethnic population with diabetes and AI. And then you have this is the development and validation of a deep learning algorithm for detection of diabetic retinopathy in retinal fundus photograph. This is done by Lily Peng from Google, and you can see Dr. Kim and Rajiv Raman are co-authors. Unfortunately, I don't know why both Google and Microsoft have not come out with the product, correct? And that's an advantage for Remedio, and I proudly say make in India and make for India by Remedio. Credit to Anand Sivaraman for doing, and thanks to Anand Sivaraman for making this is the conclusion and relevance they have given, even though they came out before Remedio, but still they have not got a product in the market. And there was a criticism also in the Wall Street Journal because it failed in Thailand because of they are using the regular fundus camera and internet is a problem, and that's the advantage with I don't have any financial interest because Anand or Remedio does not pay me anything. And many patients in India lack coverage and access to effective quality eye care. International Diabetes Federation has said 77 million diabetic in 2020 and expected to reach 150 in 2040. But recently Dr. Kim told us, which is published by Madras M.V. Vishwanathan group in Madras, it's already 100 million, correct Subudhi? He told us in the last, out of this 16 million people will be affected by diabetic retinopathy by 2050. And where is the number of doctors? We only have 25,000 eye doctors, maybe 10, 15,000 optometrists, and how do we manage it? Diabetic retinopathy has a significant impact on people's quality of life and was associated with deterioration in physical well-being. Besides the burden of people with diabetes, diabetic retinopathy is also responsible for significant healthcare expenditure. I hope our Prime Minister will listen to me. This is what my dream. Above the age of 35, we want every individual to be tested for HbA1c, random blood sugar and PP blood sugar. It's not easy. We are doing it daily in the Dharavi slums. We have visited 330,000 slum houses. But this is what I want every village to be covered in India. Somebody should sponsor for the blood test, and then you should use any camera, but I like Remedio with it's a handheld with an iPhone, and we can go to every village and do this screening daily. The problem statement: the delay is equal to lost follow-ups, missed or postponed treatment, increase in the probability of vision loss. So you can imagine a breadwinner who's a taxi driver or a coolie, and if he has diabetes and then he has a diabetic foot and he loses his vision, the whole family will be in a problem, and that's what we are seeing in Dharavi. Diabetic retinopathy is a progressive damage to the retina, eventually leading to blindness. So as an AOS president in 2019, I made a slogan, which again you should start using it. Are you a diabetic? You may go, do you know you may go blind? And it should be translated in all the Indian languages, and hope Manoj Mathur, any of you have a team. Me, Lalit Verma and Harbans are the advisors, and Ajay Arora is the chairman of the diabetic retinopathy, and I was there for the last few years. So no symptoms until it reaches an advanced stage. If detected early, vision improvement can be prevented, and the existing DR screening process, a lack of trained clinician, but I think I am replacing the clinician with anybody. So I have a term called ABCD, borrowed from our Prabhu Deva in that movie, Anybody Can Dance. I now say anybody can screen for diabetic retinopathy, and moreover the screening process is time consuming. So actually I am doing this program so that every ophthalmologist, every diabetes doctor, as well as the patients will benefit, and thereby reduce the cost of healthcare in public hospitals. For diabetes affects the head, you have the stroke, then eye blindness, then you have heart attack and death, and then you have this Rakesh Jhunjhunwala. Every paper has written the headline, he died of cardiac arrest. He died of diabetes. And I think that one of the diabetologists says, die in bits. Why should you die? According to me, if you diagnose, as I said, every year you are doing HbA1c from the age of 35, and 36, 37, 38 you are normal, and 39 you see your HbA1c is going above 7, and that's the year you can take it as 0 year for diabetes, and then it will take 5 years for retinopathy to happen. But we see patients, I'm sure all of clinicians will see, they will say only 2-year diabetic and they'll have a loss of vision. So it's too late. So I think we have to educate the people, and we can use anybody because they don't have to know the funders and they don't have to know all this, and they just put the AI application and it will say it's 100% sensitive. And DR is an important public health problem. So I always laughed at my public, PSM, public and social medicine professor. When I remember still, he used to scold me because we were laughing at, he will say we can prevent this, we can prevent that, and I laughed at him. But now I am following public health ophthalmology, and retinal photography is a validated, simple and effective for diabetic retinopathy screening, and we have treatment. So we detect early. You have the patient vision at 6.6, 6.9, diagnose early macular edema, diabetic retinopathy, early diabetic retinopathy, or even pre-proliferative. You can do laser and maintain 6.9 and 6.6 vision. And DR screening programs are challenged by issues related to implementation, availability of human assessors, and long-term financial stability. In order to overcome practical challenges like remote location, that's where Dr. Manoj was telling, post-COVID in the cities, Manoj, we don't have to do telemedicine, but even in city, I remember talking, we made a telemedicine for ophthalmology and telemedicine for optometry. So where we want to empower the optometrists to do the vision, OCT, fundus photo, and send it to us, and then we can guide them. So we are now doing this for, I am now a visiting professor in Poland, and we are doing this for Ukraine. We are giving them the live example of how to manage a foreign body or a complicated vitreoretinal problems with the Professor Robert Radak. So there is a role, but not in the cities, but in the war-struck area and also in the villages of India. And recent studies indicate AI has astounding potential to perform much better than humans in some tasks. Anyway, that word much better than human has to be replaced with some other word, maybe good assistant, especially in the image recognition field. There's a beautiful movie in Tamil called I forgot now, on Alexa, how Alexa is playing an important role in an husband and wife, and Alexa counsels the husband. And it's all too much, but and I think in the robot movie, the robot wants to make love and produce child. I mean, that's the extreme fiction, but one day science fiction will come true. But I think we can use for a betterment for the patient. Early detection and appropriate treatment of eye disease are great significance to prevent vision loss and promote living quality. And that's what I want to tell diabetic patient having heart problem, kidney dialysis. What is the point? What is the quality of life? You should enjoy life. And in UK, 50-year diabetic with no complication is getting a medal from the Queen, and then 25 years get some prize. So I think we have to introduce that to in India also. And AI was used to predict DR risk and DR progression among diabetic patients to combat with this worldwide disease. So smartphone-based retinal imaging is an efficient and cost-effective method for screening, thanks to the Sosale and Anand Sivaraman, the brain behind it. The device can help in delivering eye care service to underprivileged population groups in resource-limited or remote area. So we did a part of the community ophthalmology, the OSWB in Durgapur, Subudhi. That was a great program. They did it with Rotary. And to get diabetic patient in a diabetic camp is a big problem. And in this thing we got only about 10 or 20 patients, but they kept the place remote. So we have to have a system to do it in daily basis. So we are doing in BMC, that is the Bombay Municipal Corporation, daily, but they have 199 like PHC like center called Apla Davakhana. Our Prime Minister inaugurated it. I have given a proposal with Anand Sivaraman. The municipal corporation has a 27,000 crore as budget, equal to some state budgets of India, and where I told them buying 200 cameras will cost some only 8 crores. So why can't you do that? Anyway, the commissioner said yes, but they have not done it. And I want them to put the money, and I want to put their people, which Kerala is a great experiment by Dr. Shobha Shivaprasad, who is my co-author, as well as Anand Sivaraman. Kerala government, the NHS gave 16 camera, and Remedios sold another 150 camera to the they call it Family Health Center, FHC, instead of PHC. And that the health minister is Sheila John, I think, who's removed politics, but she did it. I mean, they are doing it daily and they are having a statistics to the health secretary. Similar thing we should do. Tara Prasad Das keeps talking, I don't know what's he doing, but you should take over. He's become old. And it's an ideal platform for comprehensive telemedicine, enabled eye health screening, and detailed photo documentation for diseases indications such as cataract, glaucoma, vitreous, and retinal pathology. AI has the potential to significantly enhance and impact on screening program for vision impairment and eye diseases, and thus to impact on global blindness. And at this juncture, I want to say there is a Vivekananda Educational Institute in Chembur called VESIT, and there they have given me a 2,000 square feet space. So it's called Aditya Jyot VESIT Aditya Jyot Innovation Center. I want to create a reading center, image reading center with AI, so that continuously it can be a one day a big data, maybe can be co-owned by the TOC and maybe Remedio and the VESIT. Integration of retinal photography and AI is based on grading and diagnosis system for referable diabetic retinopathy, glaucoma and cataract. Now this is AMD and cataract. This is what Remedio has done now. Performs the following procedure fully automatically. Identifies the fundus features, classifies the image quality, classifies the existence and severity of disease. That software tells the person who is taking photo, the patient, the photograph is 99% good quality or not. So I think it can reject the paper, and the individual photographer can improve their quality of taking photograph based on deep learning technology. So screening can be performed using the portable equipment. So we can say that Dhirubhai Ambani said, "Duniya mutti mein," he said, but you can see using the mobile you can do it, and that will give a false impression that you can take a mobile and take a photograph, but they have an infrared device attached to the mobile and you can do that. And we can have the referable diabetic retinopathy, which can be referred to an eye doctor. And AI is based on the deep learning technology. It can be used to detect referable cases of diabetic retinopathy. So advantages: increases accessibility of screening program in the low resource area, enable non-eye trained clinician to conduct opportunity screening without the need for trained specialists, savings to health system by providing more targeted referrals. That means if you screen 100 people, only 4 or 5 have to go to the retina specialist. 95 can go home, and every 6 months they can come for a retinal photograph. And real-time reporting of results and referral recommendation reduces patient anxiety, reduces documentation errors, reduces difficulties recontacting patients. Is this a sustainable screening solution for community screening in India? So that's why I made a Stop Blindness initiative. Stop Blindness stands for screening through Tele Ophthalmology for prevention of blindness. And there was a lot of questions asked to me, and Subudhi knows, in the AIOS, and is it going to be useful? But we did 3,000 camps in 2019 when I was the president of AIOS, and that was haphazard. That's why Remedio I want in Maharashtra to do this as a planned with a pro forma, and do maybe 200 centers and publish it in any journal. Similar thing you can do in Orissa. He's a clinical research head, so he can guide you. And this is what I made a slogan: every Indian citizen deserves an eye checkup. And I think it is there in the Constitution in India: freedom of speech, freedom of thought, and also every individual needs their health to be taken care by government. So this is the Remedio fundus on phone, can be mounted on a suitable bike. I don't hand the handheld because the examiner's hand is not stable, and the patient also not stable. But Anand, and yesterday I saw Saurabh and team, they are very expert in seeing in the bright light in the in the exhibition area. So it's a chargeable, portable, low maintenance job opportunity for any school dropout, and easy retrieval of data at reading center. So I think how many million, I don't know, you have in Remedio. They have so many million images now. So selection of screening device. The reason is we have only one ophthalmologist every 1 lakh population, and we need, I think, 45,000 optometrists. This is old data published in IGO. Now I don't know. I don't know how many optometrists are there. Any idea? The whole India, yeah. I know. So less blindness preventing surgery. It is vital that optometrists take charge of primary eye care and semi-skilled workers take charge of screening. There's a lot of questions, and I think MP, the optometrists are empowered with something, but there is a quack practice also started, unfortunately. What, Subudhi? There are some places they are using optometrists as I don't know what is it, ophthalmic assistant can be like eye doctor in MP, and that fellow is doing cataract also. That's a problem. In Africa, it's officially allowed. Proper training of the semi-skilled, that's what is important, accountability, semi-skilled worker, and make sure they don't cross their limit, proper and regular monitoring, ease of workflow, like easy retrieval of data, uploading of diagnosis for retina specialist, treatment and general advice given, and regular interval visits for screening team. So if everybody does this regularly, they can take care of the diabetes, they can take care of the diabetic foot, and also lead a happy life. Early detection and treatment after screening can reduce the prevalence of diabetic retinopathy even in remote area. And I think we have now crossed the population of China, and we are doing 6 times more than China in cataract. So that's called the cataract surgery rate. And similar thing we should do. They are also advanced in AI in China, and I know twice I went and gave a talk, and they are also using AI for DR. But we should now excel and publish more to say we are the number one in the world, and I am the treasurer of ICO. I am seeing India should be the leading for diabetic retinopathy screening, and I am trying to make a document on DR screening for the entire world. And because AAO is ruling, but I want to supersede AAO also. The Media's algorithm is Media is a company made by two guys from Singapore. Now Media's has taken over by Remedio, and it has an algorithm designed to diagnose only referable diabetic retinopathy and no diabetic retinopathy, and this was the one. And so this is a AI tool, is not replacement for a doctor, and this is what we are using. We have published this diagnostic accuracy of community-based diabetic retinopathy screening with an offline AI on a smartphone. And this was a prospective cross-sectional study, took place from August 2018 to September 2018, and patients with diabetes who visited various dispensaries administered by the Municipal Corporation of Greater Mumbai in Mumbai on a particular day were included, published in JAMA, and known cases of diabetes visiting the municipal dispensaries of Mumbai were included. Fundus images of both the eyes were taken and uploaded and saved on cloud storage space. And this is an ophthalmologist seated in a distant location, sees the image and grades the immunity. So this is how the
acquire new images.
So you can see that anybody can focus like this and take a good photograph, and then that can be stored, and then you apply the AI to see whether the patient has a referable diabetic or. So it's better to do this in the dark area so that you will be able to get a good photograph, and then so you can see he can focus, he or she can do the focus and take photograph. So this is the first study validating performance of an offline AI algorithm. This is the first study using AI on images taken by a non-specialist in outside of clinic setting, and FDA superiority endpoint for referable diabetic retinopathy is sensitivity 85.0%, specificity 82.5%. And the sensitivity and specificity of AI in detecting referable diabetic retinopathy was 100% and 88.4% respectively compared to ophthalmologist grading, no false negative, and the sensitivity and specificity of the offline AI in detecting DR was 85.2 and 92% respectively compared to ophthalmologist grading. And here the comparison with other studies which is published, and I don't have any financial interest. And advantages: an offline AI does automatic grading of the retinal images. Reports can be made easily available to the patient and to the doctor. An offline AI for community referable diabetes screening using a smartphone based on fundus imaging system increases job opportunity. GP, primary care physician, and other caregivers can easily diagnose referable diabetic retinopathy using this simple and affordable innovation. The potential to make a huge impact both on the disease of diseases, social and economic dimension, and advanced image processing capabilities allow clinicians to work with the even low resolution fundus images, relatively lower. That's where the advantage over the Microsoft and Google, I think, where they used quality images which does not work in the field, and relatively low cost than manual methods. And advantages, highly scalable process with quick response time, accuracy about 90% according to the initial pilots, which improved as additional data sets are gathered. Solution is extensible for glaucoma and AMD. Emerging healthcare technologies focus on reducing unnecessary visit to medical specialists, minimizing the overall cost of treatment, and optimizing the number of patients seen by each doctor. And a negative AI-based finding may give the patient a false sense of security, and which I think we can take care. And this is the community DR screening we did in, thanks to Remedio again. We had come in the Guinness record. 649 diabetic patients were screened and 53 were diagnosed with retinopathy, and we have done free treatment. So we had used 13 cameras at the time. AI for screening is equal to accessibility, affordability, and efficiency of service. Thank you very much.
Thank you very much, Professor Natarajan, giving us a wide view of role of AI in DR screening and in almost all eye diseases, blinding eye diseases. It's a wonderful overview you have given. And now I request.
In the meantime, can you give a comment?
Dr. Arvind.
Can you give a microphone to him? You
Yeah.
come, sir. You come here. Moria, you come.
In the meantime, Dr. Arvind, you can get ready your presentation. I think. Anand, you come here. Come.
A couple of things I want to ask the panel as well. One of the things now what Remedio is trying to do is we are trying to put these devices in the diabetologist clinic, right? Now that's, if you go and ask the patients in the diabetology clinic, yeah, you have sugar, you come here every time, have you checked your eyes? None of them are checking their eyes, and even the diabetologists, we ask them, do you know that there is something called retinopathy? They are like, oh yeah, we know about it. Do you refer your patients to an ophthalmologist? No. So one of the tele-ophthalmology model which can be implemented is at-risk population. We are seeing at-risk populations there and can be seen. The second question is to you, sir. So when you talked about this guidelines, is there any specific guidelines there? It speaks about the couple of things. One is about the data security. Now anyone can take a photo and then send it via WhatsApp. Where is this data stored? Is it stored within India or is it going outside abroad? That's one of the problems with the tele-ophthalmology, and we are making sure the data doesn't cross the boundaries, and India is very clear about that bit. The second is, what should be, how far should be the ophthalmologist when compared to the patients? For example, I am here, can you sit at Delhi and then do it, or is there any limit that's the guidelines put it to it?
Telemedicine, it can be by different modes, like it can be RMP to the patient directly, then it can be RMP to the optometrist, a healthcare worker in between. The healthcare worker does direct consultation with the patient, relays the information to the RMP, and then they can take a call. The boundaries are not specified in the guidelines. So Natarajan from Mumbai can examine the patient in New Delhi, should not be an issue. And as far as the data by WhatsApp messages, like this thing is concerned, like, yes, I don't know, you may be right, the main data may be going, but it is supposed to be an encrypted data, may not be accessible to other users, but in the server, I don't know. I don't know the technical, these things. Boundaries, yeah, yeah. I'm not sure about this WhatsApp data, whether they can store the image. Maybe in the server, is it stored? You have any information? Like, it is supposed to be an encrypted data, which can be seen only by the recipient and the sender. No idea. Yeah. Yes. I think WhatsApp, they have a server in India only.
Their property, and that's why the controversy started. But I think same thing happened to the blood also. That's why ICMR does not allow any DNA and obviously cross the border. The problem also for research, but same time we have to protect our own blood. Yes, sir. Murali is a professor in AIMS, Hyderabad, and is a gold medalist.
Good morning, dear friends, and thank you, Professor B.N.R. Subudhi sir, Padma Shri Professor S. Natarajan sir, and the Honorable Treasurer AIOS Dr. Manoj Mathur for giving me the opportunity. So my talk is on artificial intelligence-based smartphone applications in ophthalmology. So as we all know that these mobile-based technology, these are the future of telemedicine, and these outreach activities, they need to be centered around the home, and the visual acuity and visual field screening apps are easily available on the smartphone applications. And these are capable of detecting visual degradation even before they present to a healthcare professional. And the patient feel more engaged and improve their compliance with these easily applicable smartphone applications. And these smartphone applications are capable of improving the disease outcomes also. Regarding the mobile applications, there are more than 700 applications, both Android and iPhone based with eye care themed, and out of these 259 applications are of some or the other use for the general health care. And these 131 applications are relevant exclusively for the ophthalmic practice. Regarding the cost, so 76% of these applications are available free of cost, and around 22%, these are 30 out of 131 need a monthly or annual payment ranging from $5 to $22 per month. And in about 2% of these applications, the developers have provided a free trial of up to 2 weeks. Regarding the distribution of these applications as per utility and operating system, so it ranges from vision screening, eye exercise, professional education, calculator, color blindness test, low visual aids and assistance, patient education, data collection, and in amblyopia also. Regarding the very important aspect is the reviewer rating and validation. So these 13 applications had more than 500 reviews and all designed for non-eye care professionals. And the eye test application designed for the general public has the largest number of reviewers ratings. And the application with maximum reviewers rating is a smart optometry app with 50,000 downloads and 680 reviews. Validation, so only 4%, that is only a very small fraction, that is 6 out of 131 applications are claimed by the developers to have undergone some validation test. And 3 applications were designed by the eye care professionals without any involvement of the developer. And around 10 applications were endorsed by the eye care professionals and healthcare institution. My Vision Tracker is the first ophthalmic application to be US FDA approved in 2014. As we go through the mind map of the scope of these smartphone applications in the eye care, so it ranges from the surgical videos, emergency manuals, eye care, these graders, questionnaires, health calculators, to the data collection and the visual acuity and eye exercise, amblyopia treatment, etc. So I will take examples of few of the commonly available these smartphone applications which are relevant. So Peak Visual Acuity app is highly validated because it is developed by the International Center for Eye Health Department of Clinical Research in London. It is capable of accurate and repeatable acuity measurements in either set in the elderly population. Also, it is an efficient tool for the school screening kits also, can be used by non-ophthalmic staff in emergency department, and the Chinese and Australian population, as per one study, they have also shown satisfactory results. Then comes the ophthalmology guide. It is a well organized and topic oriented e-book application. So there are systematic details of every topic and subspecialty of ophthalmology. It includes the latest ophthalmic instruments. Clear categorization makes very convenient for all ophthalmologists, and it finds the specific guidelines accurately and quickly during their busy time in the clinic. Then comes the iTube application, just like YouTube, with a global ophthalmic video pool. So it collects the professional videos in ophthalmology, and it has an aim of ophthalmological educational and surgical videos with free access. Breaking news and cutting edge videos of ophthalmology practice management, they are updated every day. It saves time and energy when compared with searching on YouTube or Google. Then comes the community eye care application. So it is a free online and offline access to peer-reviewed articles. It aims to improve the standardization and enable easy access to eye care knowledge for all categories. It is supported by NGOs such as the Conrad Hilton Foundation, Sight Savers, Orbis, and Seva Foundation. Then comes the very good application, that is eye handbook application in the diagnostic and treatment reference. So it is a one-stop shop for multiple need of ophthalmic practice. It offers a dozen features to both ophthalmologists as well as eye care workers. So there are educational videos, calculators, testing tools, practice efficiency tools, coding tools, journal portals, and treatment reference manuals, along with discussion boards also. It is one of the most popular application among the eye care professional, with over 500,000 download and 25,000 active user at any point of time. So several studies have mentioned and endorsed the use of this eye handbook application. Then comes the smart optometry eye test for the professionals. So there are various vision screening tests, including the color vision, near vision, amblyopia testing, Worthford dot test, Hirschberg, and the Amsler grid. So it is available in 11 languages and in both Android and iPhone. It is fast, easy, and results are accurate, reliable, and clinically validated. It is one of the most downloaded application by the healthcare professional with over 50,000 download. Then comes the My Vision Track application. So it converts the Apple smartphone into a medical device. It tracks the progression of vision damaging disease such as age-related macular degeneration and very commonly prevalent diabetic retinopathy. And the patient test data are automatically uploaded to a physician's portal for monitoring also. It is validated as a remote monitoring tool at home to track treatment effects and to detect disease condition changes. All Eyes, another application which is also FDA approved for monitoring maculopathy, and both are available in iPhone and cost about $9 per month. Then comes the toric IOL axis marker. So it is available free of cost. iToric Patwardhan, again developed by Dr. Saurabh D. Patwardhan. It is also available free of cost. Then I Know Tamil and I Know Bangla, a very good application developed by John Davis Akara and his team. So when the North Indian residents, they are coming to South India, so they have difficulty what the patient are saying. So it converts the main problems said by the patient into English, and it is also available in Bangla, and we are preparing the Telugu version. I am also part of that team. Then Dignify, very good application for the blind patient. So it converts the text into an audio file. Then Vikas, it is a visual intervention kit with analytics for the spatially able children. So there are visual exercises and improvement in the cognitive visual function is noted, especially in the children who are suffering from autism and cerebral palsy. Then OggleCam, because EMR is becoming a very important aspect in the modern world. So it is developed by Dr. Sunil J. Mehrabade. So requirement of installation is a smartphone with Android operating system 5.0 and up. It is available free of cost, and it is a very good tele-ophthalmology consultation platform, and it can be used for a smart referral. So when one ophthalmologist will refer the patient to the other ophthalmologist, if they both have this OggleCam, so that ophthalmologist will have all the record, all the data of that patient. So in the conclusion, the concerning professional educational applications such as eye handbook and eye emergency manual application, so the institution and our individuals need to endorse and make necessary relevant suggestions, and these applications dedicated to professional use must also be peer reviewed. That is missing. Validation is also missing. Studies are needed to understand the readiness and concerns of eye care professionals in adopting the mobile health, and guidelines to choose an appropriate application needs to be made. An importance of interdisciplinary collaboration in the design, development, and validation of these applications is a must. Thank you so very much.
Thank you, Dr. Arvind, giving us a wide range of apps which are available now for the teleophthalmology, and we look forward to an app which must be easy, cheaper, and friendly. So definitely, a lot of people are doing a lot of Prasanna, please. So definitely, a lot of people are working on that. Still, we are in the coming years we will get a very good app, and also our Remedio people are sitting here they will help us getting an app where each diabetic in our country can be screened with a simple, low cost. Our next speaker, Dr. Prasanna Venkatesh Ramesh, is also again, she will be speaking on the metaverse in ophthalmology. He's a really young, dynamic ophthalmologist. A lot of innovative ideas. He's a part of our Davis, Akara Davis is part of the team, and he's doing a lot of good things. So it's over to you.
Thank you, Subudhi sir, Natarajan sir, Manoj Mathur sir. Thank you for this opportunity to talk on metaverse and teleophthalmology. So the idea really, came to me, especially when you watch movies like these where there are 4-dimensional representation of holograms, right? Can we do something which is science fiction into a science-based reality? So that is when, as Arvind sir pointed out, app-based application is something that will help us in reaching more people. So my dear friends, these are the 2 apps that we launched on the smartphone. So you can take a screenshot of it. For Android we have one, and for Apple we have another. So you can get your own app today, which is actually free of cost. So what we started in a small way is, in a smartphone, you can see on the left hand side, on the right hand side. So this is my friend, the pedagogue, teacher training the students. On day 1, he can actually orient the students or the neophytes into the 3-dimensional orientation of the eyeball structures, as you can see here. So this is something that will help in accelerated learning, as well as this is the idea that we got, and now we went into creating an EMR of this sort, which will help us in guiding teleophthalmology, where we are in a place where the eyeball or the case sheet is sent in 3 dimensions, right? So if once an imaging is done, our tool is a translational software. So the place where we are sitting, we can actually examine the structures as what they are in the 3rd dimension, rather than having a 2-dimensional imaging, which is sometimes not really going to help us, because eye by itself is a 3-dimensional organ. So when we started using it, it was for teaching, like we started putting the real fundus, real gonio images, and now we are seeing the scope in teleophthalmology because of, as I told you, when you get the real structures as what they are, but the patient is away from you, but you end up examining the patient's case sheet in 3 dimensions or in 4 dimensions for that matter. So even if you have a good angle imaging, at least we can start off slowly by fundus photographs. Most of the hybrid vision centers or teleophthalmic units will have fundus photographs where you can have that installed, and our application helps us in generating the holograms, and we have color fundus, autofluorescence, infrared. You can see that this is a splinter hemorrhage of this particular patient where there is an autofluorescence. Then there is another RNFL defect in this patient where there is color fundus, autofluorescence. You can add more filters to it. That's the idea, and that's the advantage when you move into retinal examinations, right? Multimodal imaging, and this is published in the European journal, March issue 2023 this year, where we validated this app and we also published it. And also you can see in the December 2022 issue in IJO, we had a publication of smart evolution of teleophthalmology. Again, this is something that we have cracked it in for teaching level. We are now working on the level where can we really subtract structures that we don't want to. You can see there are buttons like skull, meninges, brainstem. So this may even take its toll into neuro-ophthalmology as well. So once a complete imaging of the patient is done, so we will be the one who will be deciding which structures we don't want to see. Like we go ahead, subtract structures, and then you can see that we will be having the structures that we want to see of our choice. So that is something that we are adding on to a subtractive element where we will be the one who will be choosing what we have to. And then also the counseling benefits and simulations benefits as well. So I think more of these shifts are towards the artificial intelligence and augmented reality, where we can end up examining a patient. So this is a raw skeletal template of the same. This is me actually moving the phone towards the patient's pupil. So when you move it towards the patient's pupil, you actually end up going for a fundus examination. So we are working on models where the doctor is away, but he end up examining the patient's fundus in real time. This is just a prototype model, but I think we'll get there slow and steady, as you can see in this video. Again, for diagnostics, if you see, again, this is a 4-dimensional element that we have brought in very recently. We have cracked it. The goggles has been worn, and now he is actually moving the case sheets in his hand. So the case sheets are actually examined by touch. He is pointing out the splinter hemorrhage. So the case sheet documentation, everything. So this could be an augmented reality EMR in the future, where we'll be examining the patient's case scenario, RNFL defect in the 4th dimension. Again, you can see this is a case of a retinal pathology, where there is the patient comes and you can see the imaging going into the hospital database. Our software converts it within holograms in 60 seconds. Another additive feature of our software is you can extrapolate the OCT out of the fundus images. So you can get the slices. So all that we saw in Hollywood movies, no, we have tried to bring it into as much reality as possible with multimodal imaging, 4-dimensional low vision rehabilitation. That is also something that we are working on. And neuro-ophthalmology also is something that we can explore in a much better way, where these are all gray areas of tele-ophthalmology rather. So these are something that it's all started towards it, and this journey is just an ongoing one. This is published in August 2022 in Indian Journal of Ophthalmology. So for me personally, COVID was the one which really made me into an Iron Man, I would say. When there was a crisis, that's when we went into opportunity. And even this is a simple video I wanted to show, metaverse in surgical training as well. I think tomorrow tele-ophthalmology may even happen in surgery. It's just a matter of time where the surgeon may be sitting in one place and he may be doing a surgery in another place with another robot which he may be integrating himself, which we would have seen in n number of movies. So I dropped a stent actually in this patient. So then I retrieved it. I was lucky enough, this was one of my early cases where I had minimal knowledge of the eye stent posterity or eye stent trabecular meshwork memory. And also ends well, the patient ended well. I placed both the stents, but that gave me an idea for surgical tele-ophthalmology as well. So we are now working on this one on a surgical plane as well. You can see this is the lab where this is my associate, Mr. Tenzing. He's actually moving his hands in through thin air. The hands, the right side and the left side are coded. The left side, what you are seeing is what he's seeing through his eyes. So now we have cracked the module for a surgical simulation as well. It's only a matter of time that surgical simulation is also, or real surgeries is going to happen where the doctor is going to be in somewhere, but there will be another robot where he'll be mimicking the procedures and he'll be ending up and doing the surgery being at a different place. And this is after simulation placing the stent. This is in January issue 2022. Artificial intelligence, augmented reality, they are all real and happening, my dear friends. Another publication of mine, original work last year done in IJO itself, can see we really go the extreme level. We need to go to the minute level to crack metaverse and AI. We are working on AI models as well, which not only diagnoses it, but also predicts it. We are trying to add this along with augmented reality so that you not only get the diagnosis, but also the predictions, because this really helps us in a medical legal point of view, where the doctor is more, he's the one who will be always pointed out, because he's the one who, his signature will hold the role. So when we work on AR and AI, the medical legal aspect of it, or rather the doctor is given more, we are trying to work on modules where we are trying to break the black box dilemma. So why the AI functions the way it functions. So you can see that a simple diabetic macular edema, we are trying to bring out the pockets out of it. Every single signs, can the machine predict what is it? A simple figure, can the machine predict to an extreme level where the signs are, where is the CNVM, where is the PVD. You can see even a simple PVD where there is a vitreous shadow, right, that also is being picked up by the machine. So these are some modules that we are working on. So again, this is my modeling and mitigating publication in 2021. And to summarize, machines are there, my dear friends. We are not going to fight with them. We will always be on top. It's the doctor and the machine that we are going to work towards for a better humanity. So I'm not a single person. I'm a team person. This is my team. The average age of my team is less than 25. That's what a good amalgamation of doctors and engineers, and most of them are optometrists. So we are working on, this is our startup, Mahatma Center of Moving Images Private Limited. You can catch us at www.mcmi.in. And thank you once again, Team Tosi, for giving me this wonderful opportunity to talk on metaverse. This one, sir? Yeah, I'll go, sir. Thank you, sir. The 4D I have yet to show you, sir. Definitely, I have not brought the kit, but I'll show you the 4th dimension innovation where we are doing that one also, sir. So you can get
Thank
the
you,
QR.
thank you, Dr. Prasanna, giving
Thank
a
you.
comprehensive picture of all new things developing
Thank you,
in
sir.
your factory, I would say. Really wonderful. We are looking forward to get similar and more opportunities for the TLC.
Thank you, sir.
So thank you all the viewers, all my panelists, all my chairpersons and the speakers for this wonderful session of tele-ophthalmology. And every year I thank AIOS, of course, as office bearer sitting with me. Sir, thank you very much for giving us the opportunity. And always we get in a wide, 75-minute session in almost all the conferences, AIOS conferences. Thank you very much.